Pulmonary artery thromboemboli. Pulmonary artery thromboembolism is the leading cause of maternal mortality in United States. A woman's likelihood of venous thrombosis is increased 5 times during pregnancy. All three of which are classic conditions that predispose to vascular thrombosis. Vascular trauma, venous stasis, hypercoagulability are present in pregnancy. Vascular trauma occurs to some extent during vaginal and operative delivery. Vascular trauma occurs due to vaginal and operative delivery. Venous stasis occurs during pregnancy because the venous system dilates and blood flow in the legs and pelvic vein is slowed by compression by gravid uterus. The venous stasis may be augmented by immobility associated with the bed rest. A state of hypercoagulability is induced by increase in certain coagulating factor including fibrinogen factors and factors 2, 7, 8, 10 decreases or variable changes in some component of the fibrinolytic and anticoagulation system factor and another. State of hypercoagulability in pregnancy serves to protect the woman from life-threatening bleeding during delivery, but unfortunately also predisposes to venous thrombosis and potential pulmonary artery thromboembolism. This increased coagulability is particularly significant if the woman has an underlying mutation in the prothrombin or factor V Leiden genes. The risk of pulmonary artery thromboembolism is increased both in antepartum and postmortem period. Overall, pregnancy initiates a hypercoagulable state that spans a period of approximately 10 to 11 months. The state of hypercoagulation is only temporary and will be normalized approximately 2 months after delivery. The overall risk of venous thromboembolism is stated in 1:1000 to 1:2000. The risk of pulmonary artery thromboembolism is increased in the postpartum period and this several times are common following a cesarean section delivery than a vaginal delivery. Additional factors that may increase the risk of deep vein thrombosis in pregnancy include obesity and immobility. A young, mildly obese woman was 12 weeks pregnant, otherwise healthy, when he was witnessed to pass out. She was taken emergently to the hospital but was dead on arrival, could not be resuscitated. At autopsy, she had large thromboemboli occluding the proximal segment of her pulmonary arteries. Thrombi were identified in her uterine veins. No deep vein thrombosis were detected in the legs. In the lung, nor the large thromboemboli occurring in the main pulmonary arteries. The true pulmonary artery thromboemboli must be distinguished from postmortem blood clot. Postmortem blood clot may have a layering out of the RBC from the plasma. This is an evident as a two-toned color of the clot with more on one side and tan white on the other side. Alternatively, it may simply soft or maroon. Also, the postmortem blood clot is typically soft, shiny, smooth, and easily falls apart with a handling. An antemortem clot, in contrast, is often coiled upon itself within the pulmonary artery. It classically has a maroon fibrinous and a relatively uniform maroon color on cross section. Image 23.3. Okay. Left side, it is firmer than its postmortem counterpart and maintains a shape more readily. When pulmonary artery thromboemboli is susceptible, it is advantageous to eviscerate the thoracic organs oneself to more adequately identify large thromboemboli as they fall out of the transected hilar blood vessel. Once pulmonary artery thromboemboli are detected, their origin can be verified by dissecting the legs and identify thrombi in the deep veins. On occasion, deep vein thromboemboli will not be identified in the legs, but instead may have arisen in the pelvic or uterine veins. Thank you.